Hello students, I am Mrs. Dhokne from working as assistant professor in KSKW Arts, Science and Commerce College, Sidco, Nasik. We are going to see today topic Streptococcus. So Streptococcus, which is gram-positive cocci causing pyogenic infection. In the last lecture, we saw the morphology, classification, then we studied the details of cultural characteristics, a biochemical reaction, cross-reactivity and antigenic structure of streptococci. In today's lecture, we are going to see the virulence factors and effect all these virulence factors of streptococci on the body. Streptococci, it produces toxins. These toxins, they are basically the hemolysins and the pyrogenic exotoxins. Hemolysins are two types, that is streptolysin O and streptolysin S. Hemolysin, as it is produced by streptococci, it is known as streptolysin. So hemolysin or streptolysin O, it is produced on blood agar and its activity is seen only in pore plates and in the anaerobic cultures and not on the surface of culture. If we see the activity of streptolysin, that is the zone of hemolysis around the colony, it is produced by this streptolysin O. But for this activity, we have to go for the pore plate technique for the culturing of this anaerobic streptococci, and also we have to keep the plates in the anaerobic condition as this streptolysin O is oxygen labile. The next toxin, it is streptolysin S. This streptolysin S, it is responsible for the clear zone of beta hemolysis around the colonies on blood agar. The next toxin, that is pyrogenic exotoxin. It is also known as the erythrogenic toxin or Dick toxin or scarlatinal toxin. Effect of this toxin is that it is responsible for induction of fever. So streptococcal toxic shock syndrome and the scarlet fever are the consequences of this pyrogenic exotoxin. These were the toxins. Streptococci, it also produces different enzymes. These enzymes which are having the effect on the body. So we can see here the different enzymes with their effect. The first enzyme produced by streptococci, that is deoxyribonuclease, that is streptodornase or DNase. This enzyme, it depolymerizes free DNA present in the pus and helps to liquefy the thick pus and may be responsible for thin serous character of streptococcal exudate. When this toxin it is produced, it is responsible for liquefaction of pus. This injection or this enzyme, it is made by different industries and it is purified and it is used as the treatment for the liquefaction of pus. Next enzyme is streptokinase or fibrinolysin. This streptokinase is the popular medicine used for the heart attack patients. So fibrinolysin, it appears to play a biological role in streptococcal infections. So it mainly breaks down the fibrin barrier around the lesion and facilitate the spread of infection. So when there is infection of streptococci, there is formation of or the clotting of blood, it occurs around the wound. At that time, for progressive lesion formation, this streptokinase or fibrinolysin enzyme, it acts on the tissue and it breaks down the fibrin barrier in between the tissues so that the space which is generated in the tissue, that will be free from that barrier and the bacteria can move forward, or for progressive lesion it can move forward. So plasminogen, it is converted into plasmin with the help of this streptokinase enzyme. The next enzyme is hyaluronidase. Hyaluronidase splits hyaluronic acid, which is an important component of connective tissue, aids in spreading infecting microorganism. So hyaluronic acid, which is present as the capsule around the cell, and this hyaluronic acid, it is also present as the cementing substance in the connective tissues. So when the bacteria will multiply inside the tissue, it will form the hyaluronidase enzyme. So this hyaluronidase enzyme, it will act on the tissue. It will break down the hyaluronic acid, which is a cementing substance. So naturally, the space will be there, so that from that space, the bacteria can move forward and the lesion will make more progressive. Proteinase, it is antigenic and antibodies can be demonstrated in convalescent sera. Serum opacity factor. So serum opacity factor is an enzyme, that is the lipoproteinase, is called SOF, as it produces opacity when applied to agar gel containing horse or swine serum. It is produced by certain M type of group A streptococci. Next enzyme is NADase or nicotinamide adenine dinucleotidase. It acts on the coenzyme, that is NAD, and it liberates nicotinamide from the molecule. If we see the epidemiology of the streptococci, group A streptococci, they are commonly colonized in the oropharynx of the healthy children and young adults, and there are asymptomatic colonization in the upper respiratory tract and transient colonization of skin. Sometimes the children, if they are healthy at that time, the colonization with this bacteria, it get occurred, but when the immunity is strong, infection will not occur. But if the immunity goes down or if immune compromised condition occur, at that time this asymptomatic colonization, it becomes active and the bacteria will active and will cause the infection. The common route of entry of this pathogen is upper respiratory tract. The infection, it spreads from person to person by respiratory droplets. That is, if the person is having pharyngitis. So when that person who is having pharyngitis with Streptococcus pyogenes, so the respiratory droplets, that is sneezing, coughing, speaking, all these droplets which are from this pharyngitis patient will be present in the air, and they will be responsible for getting responsible for infection to the others. Also, the bacteria, it enters in the body through the break in the skin after direct contact with infected person. Fomite or arthropod vectors are also responsible for infection of Streptococcus pyogenes. Seasonal incidences of specific disease, that is pharyngitis and associated rheumatic fever or glomerulonephritis, are more in common in cold months. So pyoderma and associated glomerulonephritis, they are more common in warm months. Pharyngitis due to Streptococcus pyogenes is primarily a disease of childhood between the age of 5 and 15 years, but infants and adults are also susceptible. The incidence of carriage is reported to be 15 to 20%. So symptomless infection helps to maintain the organism in the community. So if the carriage rate, it is 50 to 20%. So 15 to 20% people are there who are carrying this pathogen in them, but they are symptomless. But this symptomless carrier, they are mainly responsible for spreading the infection into the community. Spread from person to person by respiratory droplets or through breaks in the skin after direct contact with infected person, fomite or arthropod vector can occur. Crowding, such as classrooms, daycare facilities, where there is number of human beings, they are associated with each other, that is crowding, it increases the opportunity of organism to spread, particularly during the winter months. Immunity is type specific and appears to be associated with antibody to the M protein. Streptococcus pyogenes, it is responsible for causing the acute disease, that is the respiratory tract, bloodstream or skin can be infected and acute symptoms may occur. Two post-streptococcal sequelae, that is the rheumatic fever following respiratory infection and glomerulonephritis following respiratory or skin infection, which can occur in 1 to 3% of untreated infections. If the infection remain untreated in 1 to 3% people, the severe form of this streptococcal infection sequel we can see, that is the rheumatic fever or glomerulonephritis. Streptococcal infections are of two types, that is suppurative and non-suppurative. So first we will see suppurative streptococcal disease. So respiratory infection. The first is the sore throat. It is the most common of streptococcal disease and it may be localized as tonsillitis or may involve the pharynx more diffusely. Tonsillitis is more common in older children and adults than in younger children. Streptococcal pharyngitis, that is strep throat, is usually associated with group A organism, although sporadic cases and epidemics have been reported with group C and G. We saw the classification, Landsfield classification, in that we studied A to V are the groups of Streptococcus, but in them the A group, which is mainly the Streptococcus pyogen, which is responsible for causing the severe infection like the glomerulonephritis and the rheumatic fever. Also, in case of C and G, virulent group A streptococci adhere to pharyngeal epithelium by means of lipoteichoic acid covering the surface villi. The next infection is scarlet fever. The scarlet fever is a complication of streptococcal pharyngitis that occurs when the infecting strain is lysogenized by a temperate bacteriophage that stimulate production of a pyrogenic exotoxin. Within 1 to 2 days after the initial clinical symptom of pharyngitis develop, a diffuse erythematous rash initially appears on the upper chest and then spreads to the extremities. The area around the mouth is generally sparsed, as are the palms and soles, and the yellowish white coating initially covers the tongue and is later shed, relieving a red raw surface beneath, that is the strawberry tongue. The rash, which blanches when pressed, is best seen on the abdomen and in the skin folds. The rash disappears over the next 5 to 7 days and is followed by the desquamation of the superficial skin layer. Suppurative complications of streptococcal pharyngitis are rare since the advent of antimicrobial therapy. Pyoderma. Pyoderma means presence of the pus in the skin. It is the skin infection that primarily affects the exposed area of the body like face, arms and legs. So the infection, it begins when the skin is colonized with Streptococcus pyogen after direct contact with an infected person or fomite. The organism is introduced into the subcutaneous tissue through a break in the skin. Vesicles develop, progressing to pustules and then rupture and crust over. The regional lymph node can become enlarged, but systemic signs of infection are uncommon. Secondary dermal spread of the infection caused by scratching is typical. Pyoderma is seen primarily during the warm, moist month in young children with poor personal hygiene. The strains of streptococci that cause skin infection differ from those that cause pharyngitis, although pyoderma serotypes can colonize the pharynx and establish a persistent carrier state. Erysipelas, it is the reddening of the skin, is an acute infection of skin. Patients experience localized pain, inflammation, lymph node enlargement, and systemic signs like chills, fever, and leukocytosis. The involved skin area is typically raised and distinctly differentiated from the uninvolved skin. Erysipelas occur most commonly in young children or older adults, historically on the face, but now more commonly on the legs, and usually is preceded by infections of the respiratory tract or skin with Streptococcus pyogen. The next infection is cellulitis. Cellulitis typically involves both the skin and deeper subcutaneous tissue, and the distinction between infected and non-infected skin is not as clear. As in erysipelas, the local infection and systemic signs are observed, Precise identification of the offending organism is necessary because many different organisms can cause cellulitis. Here the image is given for the cellulitis. The other respiratory infection, that is the puerperal sepsis. So Streptococcus pyogenes, it was an important cause of puerperal sepsis with the infection being exogenous. So streptococcal puerperal sepsis used to take a heavy toll of life before antibodies became available. Puerperal fever now much more commonly due to endogenous infection with anaerobic streptococci. It was there when the antibiotics were not available. Abscess in the internal organ such as brain, lungs, liver and kidneys, they were due to this streptococci in the puerperal sepsis, and sometimes the patient will have the septicemia and pyemia. The non-suppurative complications are one in which there is no pus formation will occur. In that, the acute rheumatic fever and acute glomerulonephritis are there. So both are these caused by the immune reaction induced by the streptococcal infections, and these complications ensue 1 to 5 weeks after the acute infection, so that the organism may not be detectable when sequelae set in. In this phase, when acute rheumatic fever or acute glomerulonephritis occurs, at that time the infection will be not in the body. These symptoms of this acute rheumatic fever or acute glomerulonephritis, they are due to the cross reaction due to the cross reaction between the antigens of the body and antigens of streptococci. So acute rheumatic fever, a potential sequel to pharyngitis, and acute glomerulonephritis, it is primarily but not exclusively associated with the skin infection. Acute rheumatic fever is non-suppurative inflammatory reaction that is epidemiologically and serologically treated to antecedent group A streptococcal infection. Typically, rheumatic fever follows persistent or repeated streptococcal throat infection with a strong antibody response. The disease is caused by specific M type. Recovery from acute rheumatic fever occurs without residual injury to the joints, but permanent damage to the heart may occur. Pathogenicity of this rheumatic fever, it is poorly understood. The disease is autoimmune in nature and is believed to result from the production of autoreactive antibodies and T lymphocyte induced by cross-reactive components of bacteria and host tissue. Acute post-streptococcal glomerulonephritis, it is seen after either a pharyngeal or a cutaneous infection. So, it is most often seen in children. Immune complex deposition, it occurs into the glomeruli, and reaction of antibodies cross-reactive with streptococcal and glomerular antigen that occurs. So, what happens due to the immune complex deposition? The glomerular tissue by streptococcal products such as streptokinase, the tissue of the glomerulus, it is getting degenerated or it is affected. The function of the glomeruli that will be affected. Direct complement activation by streptococcal components that have a direct affinity for glomerular tissue. Circulating immune complexes have been found in the serum of patient with acute post-streptococcal glomerulonephritis. If you see laboratory diagnosis, after the infection, one has to go for the laboratory diagnosis. The laboratory diagnosis for the acute infection, it can be established by isolation and identification of group B streptococci from the patient. In non-suppurative complication, diagnosis is based mainly on examination of patient serum for a rising titer of antibody to one or more streptococcal antigen. So specimen for the suppurative infection is the throat swab, nose swab, high vaginal swabs, pus or pus swabs are the usual specimens collected. So serum is obtained from antibody demonstration. Microscopically, we can see the bacteria in the CSF, in the pus for the gram staining. The observation of typical gram positive cocci in chains, it is giving the primary idea of the infection that the person is having infection of Streptococcus pyogen. In contrast, smears are of no value of infection of throat or genitalia, as the streptococci, they reside there as a normal flora. So in case of throat infection or in case of genital infection, if you see in the smear, the long chain of gram positive streptococci, that is of no value. After that, after observation or observing the streptococci in the gram staining, we have to go for the culture. Culturing can be done on the different medias like on blood agar, and the culture can be sent to the laboratory in the transport medium like Pike's medium. The specimen is plated on blood agar and incubated at 37 degrees centigrade. If there is development of zone of hemolysis under these conditions, then we can say that the bacteria is Streptococcus pyogen. Sheep blood agar is recommended for primary isolation because it is inhibitory for Haemophilus hemolyticus, colonies of which may be confused with those of hemolytic streptococci. Crystal violet blood agar, it can be used for growth of the Streptococcus pyogen from the throat swab. Also, these streptococci, they will not grow on McConkey's bile salt medium. For isolation of group A streptococci from throat swab, the most common medium is blood agar supplemented with antibiotics, trimethoprim, sulfamethoxazole, or to suppress the growth of normal flora organism. For non-suppurative complication, the serological test, they are used. So, anti-streptolysin O, anti-DNase, anti-streptokinase and anti-hyaluronidase titers or antibody titers can be found in the serum of the patient with non-suppurative complications of Streptococcus pyogen. Anti-streptolysin O test is used most frequently. The ASO titer higher than 200 Todd units per ml are indicative of prior streptococcal infection. High levels are usually found in acute rheumatic fever, but in glomerulonephritis titers are low often. Anti-deoxyribonuclease, that is anti-DNase B estimation, is commonly employed. Titers higher than 300 to 350 are taken as significant. Anti-hyaluronidase, anti-DNase B, these tests are very useful for the streptococcal pyoderma, for which the anti-streptolysin O test is of less value. Commercial products are available for detection of anti-streptococcal antibodies. Streptozyme test detects the mixture of antibody against streptococci. Streptozyme test, in this test, the passive slide hemagglutination test using erythrocyte sensitized with a crude preparation of extracellular antigen of streptococci is a convenient, sensitive and specific screening test. It becomes positive after nearly all types of streptococcal infections, whether of throat or skin. So, if you see the treatment, penicillin and penicillin which is Streptococcus pyogen is very sensitive to penicillin, and penicillin resistant has not been observed in Streptococcus pyogen. Erythromycin, oral cephalosporin, it can be used in the patients having penicillin allergy. Adequate treatment during the acute infection prevent the complication of acute rheumatic fever. Prophylaxis. The patient with history of rheumatic fever require long-term antibiotic prophylaxis to prevent recurrence of the disease. Those persons who have recovered from acute rheumatic fever are given oral penicillin for many years to prevent recurrence, and because damage to the heart valves predisposes these patients to the endocarditis, they also require antibiotic prophylaxis before they undergo procedures that can induce transient bacteremias. Specific antibiotic therapy does not alter the course of acute glomerulonephritis. However, the prophylactic therapy is not indicated because recurrent disease is not observed in these patients. Antimicrobial drugs have no effect on established case of the acute glomerulonephritis and acute rheumatic fever. So in this way, the Streptococcus pyogen It is responsible for causing the diseases, the severe infection like acute glomerulonephritis and acute rheumatic fever. So here we finished the topic Streptococcus pyogen. Thank you.